Hello, everyone. This is Dr. Ayyala um, doing the lecture on glaucoma medications. This lecture is presented by MediTred, leader in online training and education. And I am Dr. Ramesh Ayyala from Tulane School of Medicine. Here are some of my disclosures, and I particularly want to thank my fellow Dr. Krasnicki for helping me with this presentation. Okay, let's move on to the main topic, which is glaucoma medications and why we use this. The goal of glaucoma therapy, as we all know, is to preserve visual function by lowering IOP or intraocular pressure below a level that is likely to produce further damage to the optic nerve. Very important concept for you to remember this. A target pressure should be arranged and individualized to the patient. So, what do we mean by target pressure? Um, This concept of target pressure has come into play in the last few years, and a very important concept for people to understand when you look at an individual patient, based on the degree of optic nerve damage and vision field loss, you set the pressure. If the patient has no damage that is noticeable, then bringing the pressure down below around 18 millimeters of mercury would be acceptable. On the other hand, somebody with double arcuate scotoma and fixation threatened visual field loss, maybe you ought to try to bring the pressure down closer towards 10 millimeters of mercury. But when we throw these numbers, you always have to keep in mind you want to give a range. So typically I write low teens, mid teens, or high teens as my target goal. And once you make a decision as to what the target pressure that's best suited for an individual patient, then you think in terms of offering the treatment. It may be that some patients deserve surgery as the first line of treatment. Majority of the patients with primary open-angle glaucoma fall into the category of medications first. And that's what this lecture will be restricted to. We will do the glaucoma surgery lecture at a later date. So, in terms of glaucoma medications, how do we lower the intraocular pressure? Either by using medications that decrease aqueous production or by increasing the aqueous outflow pathway or drainage. The glaucoma medical agents could be classified into several groups. Prostaglandin analogs are the most commonly used at this point. Then the adrenergic agents, either the beta adrenergic antagonist, which are both non-selective and selective, or the adrenergic agonist, again non-selective and selective alpha-2 agonist. And then we have the parasympathomimetic agents, the direct acting and the indirect acting or a combination of both, carbonic anhydrase inhibitors, and hyperosmotic agents. So here is a timeline as to how these glaucoma medications got into our practice. The reason why I like to put this up is well, from the historical perspective, you have to understand for almost 100 years we had only one drug to treat glaucoma, and that was pilocarpine, which was discovered in 1870. And since that time, way into 1960s, so we had nothing else going on to treat this blinding disease process. 1960s is when the oral carbonic anhydrase inhibitors and non-selective adrenergic agents such as epinephrine came into existence. In 1970s, the prodrug of adrenergic agents, what was called as propane or dipivefrin, came into existence. It's no longer, to my knowledge, being manufactured. Um, in 1980s saw the entry of the beta blockers. Um, a little history of this. When Merck introduced the beta blockers, someone noticed that the systemic beta blockers was able to reduce the intraocular pressure. And the original studies were done here in New Orleans. Um, uh, to show that topical version of these systemic beta blockers can reduce the intraocular pressure. Early to mid 1990s, the selective alpha 2 adrenergic agonists such as apraclonidine and brimonidine came into existence along with topical carbonic and anhydrase inhibitors, dorzolamide and bronzolamide. In late 1990s to 2000, of course, saw the entry of these gangbuster drugs, prostaglandin analogs, which changed the way that we manage glaucoma. Since prostaglandins came to the market, the number of glaucoma surgeries have dramatically decreased um, because of their effectiveness in controlling the intraocular pressure. Let's look at the anatomy and look where each one of these medications or these groups of medications work. If you look at the beta blockers and carbonic and anhydrase inhibitors, their main source of action is at the level of the ciliary body, ciliary processes, with the site of the aqueous production. So both of these beta blockers and carbonic and anhydrase inhibitors, they reduce the aqueous production at the level of the ciliary processes where the production takes place. Now, normally aqueous goes from here through the pupil into the anterior chamber and gets out to the trabecular meshwork. So the drugs that act at the site of the trabecular meshwork include pilocarpine. What does pilocarpine do? It pilocarpine tugs on the longitudinal muscle fibers of the ciliary body, which is inserted into the scleral spur. And so by contracting the longitudinal muscle fibers of the ciliary body, the scleral spur is pulled, consequently opening the trabecular meshwork, increasing the space in the between the fiber in the meshwork, causing more aqueous to seep into the Schlemm's canal. That's how the pilocarpine works. Whereas prostaglandin analogs work by increasing the uveoscleral outflow pathway, meaning that they help in getting the aqueous across the ciliary muscle fibers. And they do so by relaxing the muscle, the space in between the muscle fibers. And we will talk about the mechanism as to how they do that. And we have a new class of medications called the rheokinase enzyme inhibitors, which appear to act on the skeleton of the trabecular meshwork itself, thus relaxing the meshwork and increasing the outflow pathway. Now, the adrenergic agents, they both work at the level of the ciliary process and also at the level of the conventional pathway or the trabecular meshwork pathway. Let's move to the most commonly used drug at this point, prostaglandin analogs. This has become, since its introduction, a primary medical therapy for all kinds of glaucoma, especially open-angle glaucoma. They have greater intraocular pressure reduction than other classes of medications at this point. So historically speaking, uniprostone was the first of the class introduced in 1990, but it was latanoprost or the xalatan introduction that changed the way we manage glaucoma from the medical point of view. These are Eastern prodrugs, latanoprost and travoprost. And then, of course, the last one to be introduced was the amide prodrug, the bimetoprost or the Lumigan. These prodrugs are hydrolyzed by esterases in the cornea into free acids that are the active compounds that bind to the FB receptors or the prostaglandin F receptors on the iris, trabecular meshwork, ciliary muscle, and scleral spur. So in the trabecular meshwork, they increase the intracellular calcium and ionosyl phosphate. In the ciliary body smooth muscle cells, they increase the cyclic AMP levels. So prostaglandins alter the balance of MMPs, which is the matrix metalloproteases, and TIMPs, or the tissue inhibitors of metalloproteinases in scleral fibroblasts, trabecular meshwork, and ciliary body smooth muscles. So by shifting the balance between MMPs and TIMPs, what it does is to degrade the extracellular components. So the MMPs, or zinc-dependent endopeptidases, that are capable of degrading all extracellular matrix components. So what essentially the prostaglandin is doing is to um, enhance the activity of the MMPs by inhibiting some of the TMPs action. And these MMPs are helping to degrade the extracellular matrix in between the ciliary muscle fibers, thus increasing the uvascular pathway. Chronic use of the prostaglandins has been shown to alter cellular attachments on the juxtacanalicular tissue region of the trabecular meshwork, decrease collagen types, as well as fibronectin, laminin, and hyaluronan in the ciliary body. So they have various other mechanisms, but the most important one is to alter the balance of MMPs and TIMPs in the scleral fibroblast area in the smooth muscle body of the ciliary body, um, thus relaxing the muscle fibers, getting the aqueous out through that uvascular pathway. So the prostaglandin analogs increase aqueous drainage by enhancing uvascular pathway up to 60%. They do have some effect on the trabecular outflow pathway as well, but very minimal compared to their effect on the uvascular outflow pathway. In terms of the clinical efficiency, efficacy, they're dosed daily in the evening to block early morning intraocular pressure spike at the peak effect by 12 hours. It also, by using it at night, it also decreases the side effects of hyperemia. Mean diurnal intraocular pressure reduction is approximately 30% on an average. Um, Now, these prostaglandin analogs are not as effective in children compared to the adults. Maybe this may be due to a maximal amount of outflow through the uvascular pathway in children. Additional intraocular pressure reduction when added to other ocular hypertensives is known. Especially, they're very well known in combination with beta blockers. They seem to be uh, they seem to be working very well. And there are a lot of combination of beta blockers with prostaglandins out there in the market. Um, so, historically, the way they decided that the prostaglandins work by increasing the uvascular outflow pathway was to use pilocarpine, which is known to negate the uvascular pathway. And what they found in monkey models is that when you use pilocarpine, the effect is reversed. The effect of lowering intraocular pressure by latanoprost was reversed, and that's how the initial discovery was made. But of late, and so there was this concept that you should not use pilocarpine and prostaglandin analogs together at the same time, as the efficacy of the prostaglandin analogs may be lost. But more recent data suggests that this may not be true. Some of the side effects of the prostaglandin analogs that you need to be aware of all the glaucoma medications that we have, they are the best tolerated when compared to the rest of the groups that we're going to discuss in the next few slides. They have very few systemic side effects as well. Some patients can come up with a viral kind of a syndrome soon after starting it, but apart from that, there are no known systemic side effects. They're metabolized by liver with a half-life of 17 minutes. Um, um, the use of prostaglandins in uveitic glaucoma showed no difference in the frequency of uveitis of CME. Now, this has come out more recently. The initial publications that we have done actually suggested that prostaglandin analogs can increase the risk of uveitis or cystoid macular edema in a predisposed patient, not in everyone, in a predisposed patients. And now these are considered to be class C medications from the pregnancy point of view and something to be avoided during pregnancy. So the side effects that are being described along with these prostaglandin analogs include CME, anti-uveitis, and these two happen in a susceptible patient, meaning that in a patient who's got aphakia or previous history of CME, recurrent CME is the possibility. Patients with a history of uveitis, the uveitis can flare up. Conjunctival hyperemia is a very common side effect of this, or probably the most common side effect of these drugs, because of which it cannot be used in some patients. The hyperemia causes this drunken effect, and patients don't like to be seen with red eyes. Hypertrichosis is a beneficial side effect, especially in female patients, as they like these long, thick eyelashes. Periocular pigmentation is an unwanted side effect that is noticeable in a lot of these patients. Iris pigmentation. Of all these side effects, iris pigmentation is the one that is of permanent nature. Everything else is reversible here. Iris pigmentation is permanent. Okay, remember this. And the reason why there is increase in iris pigmentation, let me write this down. Okay, permanent. Okay. The reason why the iris pigmentation increases is because of increase in the melanosomes at the melanocytes. This pigmentation increase in pigmentation is seen up to 20% of the patients with blue iris over a period of 2 years, as opposed to up to 60% of the patients in patients with hazel green or mixed iris colors. And you have to counsel the patients before you put these patients on in those categories that the color of their iris could change. Periorbitopathy or deepening of the sulcus or an ophthalmos is a known entity that's come to light in the recent past. Something that you should that becomes crystal clear, especially if you're using the prostaglandin analogs only in one eye, and over a period of time, you notice the difference between the two eyes. And the recurrence of hepatic keratitis is again in the same mode as the recurrence of the uveitis in a susceptible patients with a previous history of hepatic keratitis. I think you should be careful putting the patient on prostaglandin analogs. At least the rabbit models suggested that these prostaglandin analogs may increase the recurrence rate of this hepatic keratitis. Here is the original slide from our publication that we did way back in 1998 when latanoprost was originally released. We had a series of patients, aphakic patients, who developed cystoid macular edema after we put the patients on latanoprost. And following discontinuation of the drug, the CME resolved, suggesting the possible link between CME and prostaglandin analogs. And this thing has been confirmed by other investigators following our publication. But having said that, the prostaglandin analogs are probably one of the best things that has happened to glaucoma doctors and glaucoma patients. It gave us an effective tool to control the intraocular pressure. Let's move on to adrenergic agents. These could be adrenergic antagonists, which is could be again classified into selective beta blockers such as beta-xylol, non-selective beta blockers such as the timolol, and levobutanol, metoprolol, and cartilol. Of these, timolol is probably the most commonly used worldwide, which is a non-selective beta blocker. Beta-xylol is still in the market, and we'll discuss its usage, but essentially used in patients with a history of pulmonary problems with COPD, etc., because it's a cardioselective or beta-1 selective agent, and as such can spare other systemic side effects to a lesser degree compared to timolol. The rest of these beta blockers that we are mentioning here are not in manufacturing at this point, and so you may as well ignore it, except from the OCAP's point of view. They may like to ask which of the beta blockers is sympathomimetic activity, and the answer to that is cartilol. And then we have the adrenergic agonist. the alpha-2 selective apraclonidine and brimonidine, and the non-selective epinephrine and dipivefrin. Again, a lot of young practitioners may not be aware of the usage of epinephrine as manufacturing of both of these non-selective agents has ceased, to my knowledge. And the only way you can get this done is by asking a pharmacy to compound it for you. I had a patient that I had to use not recently, several years ago, and I got epinephrine to compound for that particular patient. Okay, let's go into some details here. The beta blockers were introduced in 1978, and that again at that point was a major advancement in the treatment of glaucoma patients. They decrease aqueous production by blocking beta 2 receptors on the ciliary epithelium. Intraocular pressure is reduced by about 20 to 30%, which is pretty good. So after prostaglandins, beta blockers reduce the intraocular pressure more than any other class. Less effective in patients on systemic beta blockers, obviously, because the systemic beta blockers would have occupied some of these receptors that we're talking about, the beta 2 receptors. And so their efficacy will be less pronounced if the patient is already on the systemic beta blockers. They decrease aqueous production during the daytime, and as such, using the beta blockers at nighttime does not make much of sense. Typically, we tend to use it early in the morning, once a day, to decrease the aqueous production that appears to spike first thing in the morning in majority of the patients. Now, beta blockers have been known to be the beta blockers are known to have no effect at all in 10 to 20% of the patients. And two other things that you need to be aware of with beta blockers is one, a short-term escape, meaning that the receptor saturation can happen within weeks, and the intraocular pressure reduction that took place in the first month or so after you start the medication may shoot back to its pre-medication levels because of this phenomenon of short escape. In the long term, you got to keep watching these patients, as about 20% of these patients can exhibit what is called as tachyphylaxis or long-term drift, in which case the efficacy of the medication will decrease and the pressure starts increasing again. Now, one thing that you have to know, beta blockers in combination with a lot of other drugs works very effectively, especially with the prostaglandin analogs, whereas the combination with non-selective alpha agonists such as epinephrine is being found to be not effective. Something that they will ask you in your OCAPs. Okay, remember this. A combination with non-selective alpha agonists such as epinephrine is not effective, whereas it does work very well in combination with prostaglandin analogs, in combination with alpha-2 agonists such as brimonidine, in combination with carbonic anhydrase inhibitors. It works very well. The side effects of beta blockers, systemic absorption occurs when you place this drop on in the lower cul-de-sac, and it can be absorbed via the nasal mucosa, conjunctival vessels, and decrease. But this absorption, systemic absorption, could be decreased by punctal occlusion or gentle eyelid closure soon after placing the drop. So some of the systemic side effects that occur with these topical beta blockers could be serious and life-threatening, and every one of you should be aware of it before you start these medications on the patient. Bronchospasm, which is a beta 2 effect, and bradycardia, which is a beta 1 effect, were the two life-threatening complications that one should be aware of. It's not uncommon for a patient to get admitted with bradycardia into the hospital. Um, um, and I myself have seen a couple of these patients in asthma or bronchospasm in a patient with a past history of asthma could also be life-threatening. So be aware of these two, counsel the patients, ask for the history of breathing issues in the past, especially asthma, COPD. or any cardiac issues, especially bradycardia, try and avoid using these medications in those particular patients. Now, other side effects that these patients have include fatigue, depression, sexual dysfunction, which is uncommon, but I've seen that in my practice, masking hypoglycemia in diabetics. This sexual dysfunction is much more likely to happen in young males. Decreased serum high density glycoproteins. Other CNS effects include psychosis, anxiety, emotional liability, hallucinations. It's not safe in pregnancy or breastfeeding, so try and avoid it during in pregnant women and breastfeeding women. Use with caution in pediatric patients because of the potential effects, especially if they have asthma. Now, ocular side effects include corneal hyposthesis, superficial punctate keratitis, conjunctival hyperemia, burning, discomfort, allergic blepharoconjunctivitis, ptosis, dilated pupil, hypotony, and visual disturbance. This hypotony is a strange thing. There is an entity called a hypersensitivity reaction. A patient could be on a beta blocker for years on end, and following surgical intervention, such as a trabeculectomy, these patients, if the trabeculectomy operation does not achieve the target pressure, you put the patient back on a beta blocker. He or she sometimes can exhibit this hypersensitivity reaction where the pressure goes down to zero and can develop choroidal effusion secondary to that. So these patients, you need to back off on the beta blocker and gradually introduce beta blockers. We had a publication to this effect. I think it was first published in 1980s, if I remember correctly. And we had a few patients with this phenomenon that we encountered in our own practice. So something for you to be aware of. Contraindications for beta blockers include asthma, COPD. So these two are pulmonary problems, congestive heart failure, bradycardia, and heart blockage, second or third degree. Be careful. So every patient that you want to put up a start the beta blocker, you got to ask this history, and if they do have it, avoid using the beta blockers. Like I mentioned before, selective beta 1 blocker, the example is betaxolol. There's only drug that's out in the market. It has greater systemic safety profile without the same magnitude of IOP lowering effect as tibolol. But still, having said that, it's still not safe for glaucoma patients with respiratory disease. Um, uh, and so you um, essentially the market for betaxolol is very little. It's cardioprotective, but having said that, when a patient has any of the systemic side of disease processes in the contraindication list that I went through before in the last slide, I would not use any of these medications. So for the strategy for using the beta blockers, patients with severe disease, no contraindications, you can use the non-selective agents such as the timolol. Severe disease, some systemic concern. If you don't have any other choice, you can use the selective beta 1 agent, that is betaxolol. Severe disease, if the patient has contraindications, any of those listed in the contraindication list, avoid beta blocker therapy altogether. Choose some other mode of treatment. So here are some questions related to this because these lectures are all geared towards our residents. I like to phrase out questions halfway through this kind of lectures, especially these kind of glaucoma medications, which are kind of um, they can drain your concentration. And so to wake you up, let me ask you some questions. Here, topical beta blockers can aid reduce aqueous production to 1.9 microliters per minute, can worsen symptoms. This should have been, it's a typo there, symptoms of myasthenia gravis. Sudden withdrawal can worsen symptoms of hypothyroidism, or D, decrease HDLP and increase cholesterol level. What do you think is the correct answer? Well, the correct answer is A is true, B is true, The answer that is not true here is C, which is false. It worsens symptoms of hyperthyroidism, not hypothyroidism. And D, of course, is correct here. True or false questions. Systemic beta blocker therapy can lower intraocular pressure and hence explain certain patients who appear to have normal tension glaucoma. That's a true statement. Both beta blocker and beta agonist activity lower intraocular pressure by acting at different site within the eye. Beta blocker at the ciliary body and beta agonist at the outflow pathway. That again is a true statement. Um, More than 90% of the beta receptors in the ciliary epithelium are of the beta 2 class. Again, that's a true statement. Let's move on to the sympathomimetic agents or the non-selective adrenergic agonists. The two examples that we have, one is epinephrine and two is dipivefrin, the prodrug of epinephrine. It used to be marketed as propane, no longer in production to my knowledge. They increase aqueous humor outflow mainly through the conventional trabecular meshwork pathway and possibly through the UV scleral pathway. Chronic usage can also decrease aqueous production. They are not additive with beta blockers, so you don't want to combine the use of epinephrine with timolol. The ocular side effects of sympathomimetic agents include initial vasoconstriction followed by rebound injection, allergic conjunctivitis, tachyphylaxis, cystoid macular edema, pupillary dilation with secondary blurring, and rarely tachycardia and elevated blood pressure. Because of all of this, plus the weak intraocular pressure lowering effect, it's no longer being used. Here is a patient of mine who was on epinephrine for a few years and developed these adrenochrome deposits on the palpebral conjunctiva. This is a favorite OCAP and board question. So remember this picture. And if the choice that is given as to what this could be, these are the adrenochrome deposits on palpebral conjunctiva. The systemic side effects of the sympathomimetic agents include hypertension, tachycardia, arrhythmia, headaches, and nervousness. Because of all these issues, plus their efficacy in reducing intraocular pressure is not as good as the other medications. Manufacturing of this has ceased, and people no longer use these drugs, at least in the US. The adrenergic agonist or the alpha 2 selective agents, these drugs are originally brought to light from the effect of clonidine, which is a systemic alpha agonist decongestant. Um, they act to decrease aqueous humor formation at the level of ciliary epithelium by 20 to 25%. They include apraclonidine or iopidine and brimonidine, which is alpha-GAN. Alpha-GAN P that's in the market, with the P there stands for the preservative that's being used, which is the purite, chlorine dioxide. The rest of the agents that we have in the market, they all use BAK as the benzyl, BAK as the preservative, and we will uh, go through the toxic effects of BAK later in the talk. Remember, alpha and P, the P stands for purite, which is the preservative that they use for it. So let's discuss iopidine, which is the first alpha 2 agonist that was introduced into the market. It has some alpha 1 activity as well. Because of the alpha 1 effect, it causes conjunctival blanching and lid retraction. It was originally developed to diminish iris bleeding during peripheral iridotomy by vasoconstriction effect, but IOP lowering effect is most significant. But its usage, the chronic usage has been restricted because of the side effect profile. A lot of these patients over a period of time develop severe um, uh, uh, conjunctival side effects, and because of which we no longer use it for chronic usage purposes. But it's used as a one-time application prior to argon laser trabeculoplasty or iridoplasty or peripheral iridotomy. both for vasoconstriction purposes and also to decrease the spike, the intraocular pressure spike that is known to occur soon after these laser procedures. Whereas the alpha-2 agonist, brimonidine, is 30 times more alpha-2 selective compared to iopidine, and it has some potential neuroprotective effect. Brimonidine-treated rodents appear to have less ganglion cell damage. Having said that, this was never proven in humans. Equivalent to iopidine in preventing IOP spikes following laser therapy. It crosses the blood-brain barrier and so has more CNS and systemic side effects than iodine. An important fact for you to remember, especially in pediatric population. And it's one of the reasons why you do not want to use brimonidine in pediatric patients. Some of the systemic side effects of this class of drugs, including dry mouth and nose, fatigue and somnolence, especially in the older population, mild mydriasis, decreased heart rate, and resting systolic blood pressure. Contraindications include concurrent use with monoamine oxidase inhibitors and tricyclic antidepressants due to risk of severe hypotension. Pregnancy, these epreclonidine is classified as a category C, whereas brimonidine is categorized as category B1. Brimonidine is the only drug that's to some degree approved in pregnant ladies, as it epreclonidine certainly should not be used. However, effects unknown and should be avoided in pregnancy if possible. Okay. Contraindicated in pediatric population, like I mentioned before, because of a history of hypothermia, hypotension, hypotonia, apnea, and seizures. The ocular side effects include a high incidence of ocular side effects in up to 10% of the patients, allergic follicular conjunctivitis, burning, itching, conjunctival hyperemia, photophobia, and blurred vision. Of this, allergic follicular conjunctivitis is the most frequent reason why we tend to discontinue Alphagan or the brimonidine usage. Here is a patient in my own practice. When these patients present, they have this following the initial few dosages of application, they can present with this raccoon kind of eye allergic reaction, which is pretty dramatic when you see this. And and of course, you got to discontinue the medication when the patient presents to you like this, and usually it disappears within a week or so. Some questions on this class of medications: epinephrine, true or false, increases uvascular blood flow. B, alpha-1 adrenergic agonists cause dilated pupil. Alpha-1 adrenergic agonists cause lid retraction. Alpha-2 adrenergic agent agonists cause IOP reduction. And the answer is true on all accounts. Which topical medication should be avoided in 1-year-old with congenital glaucoma? And of course, we went through that answer, and the answer is brimonidine. You don't want to use alpha agonists in children. Can lead to increased risk of somnolence, hypotension, seizures, and apnea. Let's move on to parasympathomimetic agents. The miotics, as I mentioned before, at the very beginning of this lecture, are the first class of medications used to treat glaucoma. These could be direct acting, such as pilocarpine, and the most commonly used indirect acting, ecothiopate iodide. Its production right now is in limbo. I don't think it's available anymore in the U.S. at least. And a combination medication called carbachol. So in terms of their efficacy, pilocarpine and carbachol are considered to be weak, and ecothiopate iodide, or what is marketed as phospholine iodide, is considered to be strong. So the direct acting agents such as pilocarpine mimic the action of acetylcholine and cause depolarization of muscles, motor, and plate. Remember this, whereas the indirect acting agents such as the phospholinidide, block the destruction of the endogenously released acetylcholine by binding the cholinesterase present at the neuromuscular junction. And there's something for you to remember from your OCAP's point of view, the mechanism of action of direct agents, which is similar to acetylcholine, whereas the indirect acting agents, they block the destruction of the endogenously released acetylcholine. So these cholinergic agents increase conventional outflow and decrease UV scleral outflow. Okay, frequently asked question. Um, they increase the conventional outflow and decrease the UV scleral outflow pathway. Opens the trabecular meshwork by constriction of the ciliary muscle and pulling on the scleral spur. I think we went through this mechanism of action in the pathophysiology section in great detail, so I'm not going to spend too much time. Sufficient to tell you that meiosis is not the mechanism by which the intraocular pressure is reduced by these cholinergic agents. Meiosis, in fact, is an unwanted side effect in regards to intraocular pressure reduction. But we do use this action of pupillary constriction to help us in patients with narrow angles. So the other actions of cholinergic agents include meiosis, secretory activity in lacrimal and salivary glands. They do disrupt blood aqueous barrier and hence may worsen patients the inflammatory status in patients with uveitis. Longitudinal ciliary muscle contraction, which is how they actually tug on the scleral spur and thereby open up the trabecular meshwork and decrease the intraocular pressure. But because of this because of this contraction, remember the longitudinal ciliary muscle is inserted at the other end on the ora serrata, and so there's mechanical traction on the ora serrata, and if the patient has a weak area of the retina adjacent to that, can induce a retinal tear and detach retina. Rarely though, but has been described in literature. There's relaxation of zonules, increased because of ciliary muscle contraction, increased axial lens diameter, forward motion of the ciliary crystalline lens, and induced myopia because of that. These indirect acting agents, which are the acetylcholinesterase inhibitors, the irreversible binding agent is the ecothiophyte iodide. That's a phospholinidide. That's an example of that. Their action may last up to 2 weeks. Overdosage may cause cholinergic crisis, including excess salivation, sweating, bronchial spasm, abdominal pain, and diarrhea. Remember, this is a frequently asked question in your OCAPs. They block the plasma cholinesterase, which is necessary to deactivate acetylcholine, a muscle relaxant widely used in general anesthesia. Patients may not be able to resume voluntary breathing when acetylcholine is used because of this issue here. Okay, so these agents should be discontinued 2 to 3 weeks prior to general anesthesia. Again, these three questions are frequently asked in your OCAP, so remember this. They can induce cataracts and they also can induce irises at pupillary margin. And if they do happen, you can successfully treat this irises formation with the weak phenylephrine solution. Ocular side effects include diminished vision due to meiosis, inflammation due to increased vascular permeability, anterior chamber shallowing, and paradoxical angle closure. We discussed this aspect of it in great detail in the both in the pathophysiology section and also the anatomical narrow angle glaucoma section. Ciliary spasm, headaches, and broache. This is a real thing. If you want to start anybody on pilocarpine, you may want to advise those patients that headache may happen and may suggest to them to take some Tylenol an hour before they use the drop. Ocular irritation, retinal detachment, phospholinidide, which is a strong miotic, can cause ocular pemphigoid-like syndrome. Studies suggest that cholinergic drugs can stimulate conjunctival and corneal epithelial cell proliferation. They can induce cataracts. They can cause irises with the pupillary margin. Systemic side effects include, like I mentioned before, diarrhea, increased salivation, abdominal cramps from direct acting agents, rarely bladder symptoms, bronchospasm, positive effect in Alzheimer's patients. So the contraindications for this include malignant glaucoma, um, uh, uveitic glaucoma, pigmentary glaucoma, traumatic glaucoma, anybody status post retinal detachment surgery, PRP or cryopexy, acute central retinal vein occlusion, neovascular glaucoma, nanophthalmus. Now remember, a lot of these are related contraindications. Um, there's absolute contraindication here, except in malignant glaucoma, you got to use a cycloplegic agent to push the lens back. You will worsen the condition if you use a cholinergic agent here. Non-ophthalmos, similarly, sometimes you can worsen it can cause paradoxical worsening of the pupillary block mechanism um, by forward motion of the lens in an already compromised chamber. So if you understand the pathophysiology of these narrow angles and why they happen, you know why you should not use them. Let's come to these true or false questions. Pilocarpine is the most commonly used indirect acting anticholinesterase agent. True or false? Diarrhea is a known side effect of ecothiophyte iodide. C. Methazolamide is better tolerated than Diamox 250 milligrams. And D. Succinylcholine can be used safely while on pilocarpine. So the pilocarpine is a direct-acting cholinergic agent, not an indirect. Acetylcholinesterase is an indirect-acting anticholinesterase agent. It inhibits enzyme acetylcholinesterase, prolonging the action of naturally produced acetylcholine. And yes, it's metabolized by the liver. That's methazolamide is metabolized by the liver, so better tolerated than Diamox. And yes, indirect agents should be avoided. Um, 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 Succinylcholine can be used safely while on pilocarpine, and that's a true statement. It is the indirect agents that should be avoided when you're planning general anesthesia with the succinylcholine. Let's move on to the next group of medications, carbonic anhydrase inhibitors. Nearly total 99.9% inhibition is needed to achieve IOP lowering effect. Um, uh, So they reduce aqueous secretion by inhibition of carbonic anhydrase isoenzymes 2 and 4, resulting in decreased bicarbonate ion secretion in the posterior chamber um, by the non-pigmented ciliary epithelium. So remember this, it's isoenzymes 2 and 4, and they it results in decreased bicarbonate production, secretion in the posterior chamber. Isoenzymes 1 and 2 are important for corneal epithelial pump function. Um, Topical carbonic anhydrase inhibitors have preferential affinity for carbonic anhydrase 2 isoenzyme, while systemic non-selective action on isoenzymes 2 and 4. Rare reports of reversible and irreversible corneal decomposition have been or seen in publications from topical use in the literature. Um, how far this is true is debatable, but we see these patients occasionally. You put the patient on carbonic anhydrase inhibitors, and the corneal decomposition worsens. We really don't know if it is because of this isoenzyme um, blockage or it's the natural progression of the disease process. Systemic use is shown to have greater IOP lowering effect than topical. So there's a 29% reduction with acetazolamide oral versus 70% with dorozolamide when given topically in one study. So the topical carbonic anhydrase inhibitors include the dorozolamide and brinzolamide. The oral IV medications include the acetazolamide and the Diamox, and the oral one, the other oral that's commonly used is the methazolamide or neptazine. They can be associated with some serious life-threatening side effects. Topical carbonic anhydrase inhibitors exhibit much fewer systemic side effects than compared to the oral ones. The short lasting acute diuresis with oral carbonic anhydrase inhibitors has been described. Now, they do exhibit paresthesias, headaches, taste alteration, malaise, fatigue, weight loss, anorexia, depression, GI distress, metabolic acidosis, nephrolithiasis. Now, this is the serious life-threatening complication that we're talking about. Rarely, bone marrow suppression, thrombocytopenia, aplastic anemia, and hyperkalemia. So be aware of this. Rarely, I've never seen this in my own practice, but has been described in literature, so you should be aware of it, and something that they do ask you in your OCAPs. The ocular side effects from the topical carbonic anhydrase inhibitors include allergic conjunctivitis, periocular contact dermatitis, burning, superficial punctate keratopathy, blurred vision, pruritus, and irritation. The oral version includes the acetazolamide 250, which is given 4 times a day. The slow release version, 500 milligrams, which is given twice a day. The metazolamide or the naptazine, which is 50 milligrams, POBID or TID. I generally use 25 milligrams, and that's very well tolerated. Um, Precautions with carbonic anhydrase inhibitors. These are sulfonamide derivatives, and so they're contraindicated in patients with sulfa allergy or hypersensitivity reactions. Be cautious in patients with Fuchs corneal dystrophy and other endotheliopathies because of that controversy that it may tip the balance by blocking the carbon anhydrase enzymes in the corneal endothelium pump mechanism. Chronic emphysema bronchitis, renal dysfunction, pregnancy and breastfeeding, concerns for acidosis in premature and newborn infants has been described. But it's well tolerated in children actually. Now, the durosoloamide or TrueSoft requires an acidic pH for it to be maintained in solution form for stabilization purposes, and because of that, this acidic nature, it results in stinging and burning when the drop is instilled. Something that you may want to tell your patients before prescribing this medication. The brinzolamide has a viscous suspension, and as such, it can block or blur the vision soon after the drop is instilled. But overall, better tolerated than dorzolamide because it lacks that stinging. So as a monotherapy, it reduces intraocular pressure by about 16 to 24%. As an adjunctive therapy to especially beta blockers, it reduces intraocular pressure by additional 10 to 20%. Less effective than prostaglandin analogs and non-selective beta blockers, but has similar potency as beta-xylol and bromonidine. Let's move on to osmotic agents. They increase the blood osmolality and thereby reduce intraocular pressure by drawing water from the posterior chamber and vitreous cavity. They do have some serious systemic side effects that can precipitate renal or heart failure. Now, the mannitol, isosorbide, and glycerol are the 3 common ones that we use. Remember the dosage. And isosorbide is safer in diabetic patients than glycerol. Glycerol has a sweet, sickening taste. Remember that, and avoid in poorly controlled diabetic patients as it can increase the blood sugars. These agents are associated with mental status changes, congestive heart failure, subdural and subarachnoid hemorrhage, and then backache and ketoacidosis in patients with diabetes, especially the glycerine portion of it. Okay, let's move on to combination agents. I'm not trying to skip over the osmotic agents. We don't use it that often anymore in glaucoma management, even in patients with acute glaucomas. Like I mentioned in my angle closure glaucoma lecture, I generally prefer to do a paracentesis to abort the attack, followed by laser treatment and then cataract surgery to take care of the issue. Rarely use these osmotic agents anymore in my practice, and I think that's common throughout the world. And so, but these things are important for you to remember from your exam point of view. Let's move on to combination agents that are out there. COSAP, which is combination timolol and dorzolamide. Combigan, which is a combination of timolol and alphagan. Simbrinza, which is a combination of brinzolamide and brimonidine. And timolol plus prostaglandin analog combination, which is not available in the US. And there are some other combinations that are available outside the US that includes timolol, brimonidine, and prostaglandin all put together. And I've seen combinations timolol, dorzolamide, and prostaglandin also outside this country. One important aspect that you should be aware of and also frequently asked in your board questions is the FDA drug risk category in pregnancy and as to which glaucoma medication could be used, if at all, during pregnancy. So the drug risk category is in 5 grades: A, B, C, D, E. A is obviously the safest, well-controlled studies with no risk of fetal abnormalities. B, animal studies have no risk. Clinical studies in pregnancy not conducted, or animal studies risk to fetus. Clinical studies no harm to the fetus. C, D, and E all have varying degrees of fetal risks involved in either animal studies or well-controlled human studies, and so should be avoided in pregnancy. So, in regards to glaucoma medications, the we don't have any category A medications. The two category B medications that we have are one, dipivefrin or propane, which is no longer being manufactured, and two, brimonidine or alphagan. Um, Class B, Class C include the rest of them: beta blockers, topical carbonic anhydrase inhibitors, systemic carbonic anhydrase inhibitors, prostaglandin analogs, miotics, and iapidine. And so these should be avoided definitely. If there is a, if you're stuck in a hard situation and you have to use a medication during pregnancy, brimonidine is the drug of choice. But even this should be avoided if possible. Remember also beta blockers and acetylcholinesterase or the only reported drugs compatible with lactation by the American Pediatric Association or the American Academy of Pediatrics. We want to try and avoid again brimonidine in pediatric population. So the first trimester is the most important trimester, as you all know, to avoid teratogenic action by any of these drugs. And so please consider not to use any of these drugs during the first trimester to avoid the risk. If you have to you do anything, consider laser trabecoplasty or filtering surgery in a high-risk patient. Best time to do that would be the second trimester. The IOP naturally lowers during pregnancy, something for you to remember. Use punctal occlusion to minimize systemic absorption if you have to use the brimonidine drug. So here are some medication recommendations. Months 1 to 8, beta blockers, alpha agonists, carbonic anhydrase are probably okay, but try to avoid it. Months 9, consider dosing all drops to avoid neonatal complications. Breastfeeding, carbonic anhydrase inhibitors, beta blockers, okay, but those after feeding, try to avoid alpha agonist. Now let's go on to preservatives that we use in these topical glaucoma medications. Benzalkonium chloride, or BAK, is the most commonly used preservative in 90% of these topical glaucoma medications. Unfortunately, we are stuck in an era where FDA trials cost millions of dollars, and no drug company is willing to change the preservative, even though we know that BAK is toxic to the to the ocular surface. So we are stuck for now, at least, with BAK as a preservative in all most of these glaucoma medications. This is the most common. It can cause a dry eyes, and cell cultures and animal human studies have suggested that BAK is cytotoxic. It kills bacteria, and because of its effect on bacteria, it is used as a preservative, and that's great. But the ocular side effects are dose dependent and can range from apoptosis to necrosis, allergy, dry eyes, conjunctival inflammation, setting the stage for glaucoma surgery failure. All of this you will see in your own practice if you do glaucoma work. And so BAK, while good to preserve these glaucoma medications in the bottle, is bad for the ocular surface. And hopefully, in the near future, they will drug companies will come forward with newer medications that are more tolerated by the uh, ocular surface. I apologize. This last few months, a few weeks have been bad in terms of the influenza outbreak and the flu season and dry hacking cough. So let's wrap up this lecture with preservative-free drops. The only three categories that are out there: preservative-free timolol, Cosapt, and Zioptan, which is tafluprost ophthalmic solution in patients who have allergy to, which is related to the BAK. Try and use these medications, and they're very effective. They're much more expensive, of course. And the IOP reduction efficacy is as follows. Prostaglandin analogs obviously have the highest reduction, 25 to 33%. Next comes the beta blocker timolol, 25 to 30%. Alpha-GAN, 20 to 30%. Pilocarpine, 15 to 25%. And Diamox, 15 to 25%. Why medical therapy may fail? Some questions for you to think. Failure to achieve target pressure. A patient may have a severe glaucoma, and you may want to lower the intraocular pressure in low teens, and then medical therapy may not be effective. So in these cases, you may want to go for surgery. Poor compliance. It's hard for patients to use these drops during a work day. Fluctuations of IOP with medicines and improper placement of the medications. One thing that frequently observed glaucoma is the older age disease process. As such, it may be very difficult for these patients to have a steady hand to put the drop in their eye. Causes of non-compliance include multiple medications. Be aware of this. You don't want to prescribe 10 different medications to these patients and expect them to use it. It's practically impossible for patients to continue to use this kind of medications throughout the day for the rest of their lives. Multiple daily dosing, again, the same issues, side effects of medications, especially red eyes, itching, burning, blurred vision. All of this will lead to non-compliance, patient misperception of the disease. If you don't discuss the disease and as to what the drug is meant to achieve, which is to lower the intraocular pressure, not to improve the vision, um, the patient may mistake the drug and may think that since the drug is not improving his vision, he may discontinue the drop. Cost is a major factor here. Please be aware of the financial status of your patient, and if the patient cannot afford the medications, no point prescribing this. I would rather subject the patient to one-time surgery and hopefully control the glaucoma that way. Inadequate counseling is a major factor in a lot of this. It's a hard disease to deal with, and hard disease both for the patient and the doctor treating it. A lot of counseling goes on in my practice, and hopefully in your practice too. So how often are multiple medications required? About 40% in the old study. In the CGIT study, mean number of medications used was 2.1. And so a lot of these patients end up using two or more medications. And consequently, you have to take into consideration not only the toxic side effects of these medications when you use more than two or more than one drop in the eye, but also the cost um, Some other questions that you may be interested to know: beta blockers should not be used in patients on a monoamine oxidase inhibitor. True or false? Aproclonidine decreases aqueous production and episcleral venous pressure and improves trabecular outflow. C. IV mannitol can induce myocardial infarction. The answers B and C are true. A is false. It's alpha 2 agonist that should be avoided, or should be used with caution in patients with monoamine oxidase inhibitors or tricyclic antidepressants. Beta blockers are pretty okay to be used in that combination. Um, True or false again, prostaglandin analogs are most effective intraocular pressure lowering agents and have the best systemic safety profile. Bromonidine is a class B agent. Nursing mothers with glaucoma can be treated with bromonidine. Prostaglandin analogs can be safely used in a 8-month pregnant woman. The answer A and B are true. B, D, C, and D are false. There are some new glaucoma medications that are in phase 3 trials right now. Riopress, you may be asked some questions on this. It's a riokinase inhibitor. It's used once a day. The triple action, it works increased outflow through the trabecular meshwork. It increases outflow through the uvascleral pathway and reducing the episcleral venous pressure. Um, So in one study, it lowered the episcleral venous pressure by 35%. So this drug, has a favorable tolerability profile, no systemic side effects that are described, and it reduces intraocular pressure by about 30%. Um, so it's a new way of reducing the intraocular pressure. This drug is undergoing phase 3 clinical trials and hopefully will be introduced to clinical practice very soon. Um, So that concludes our lecture on glaucoma medications. I thank you for listening to this lecture. Please look out for more lectures on MediTred YouTube website and look out for our CME board review courses. And I'm excited to tell you that we are very soon going to start a new website with 100 at least 100 plus video lecture series, all geared towards the resident education, along with multiple choice questions. So you can listen to the lecture, answer the questions, and thereby improve your knowledge and understanding of this disease process involving ophthalmology. So thank you and have a good day.